Give you 3, 2, 1.
Thanks. Is that the 3, 2, 1, or are you going to give me a 3, 2, 1?
I'll give it to you.
Yeah, we're ready.
All right. 3, 2, 1. You're live.
And good morning. It's Dr. R. Deukmedjian. We are doing a Deuk laser disc repair, spine surgery, left approach at L3-4 and L4-5 on a patient who has two severely degenerated discs, one at L3-4, another at L4-5, and severe back pain and left leg pain. So we're doing surgery to cure his back pain and left leg pain. He also has weakness and numbness in the left leg, so once we unpinch the nerve, that nerve should heal, but it takes about 6 months to heal completely. And after that time, there should be more signals getting down to his muscles. All right, we're going to get started. Our patient's awake. Good morning, it's Dr. Deukmedjian, okay? Are you comfy? We're going to get started. You'll be awake for the first 10 minutes, and then I'm going to put you to sleep, okay? All right, that's just my hand feeling around. Just relax. If you have pain, I want you to say, ouch. And that way I can hear that it's uncomfortable, and I'll give you some more medicine, okay? All right. Now, you've had a laminectomy before, right? I can see you have a giant scar here. I'll outline it for our audience later. But it's huge. It's about 9 or 10 inches long. And how long ago was your laminectomy? Year and a half. It didn't work too well, did it? Yeah, because you're having surgery again. Well, this is hopefully going to work really well for you, okay? Now remember, if you have pain, say ouch, but don't move your body. Don't try to wiggle away and move around, because I need you to lay still. All right, we're going to get started. I'm going to start by giving you some numbing medicine, okay? All right, you'll feel a little pinch and a burn. I apologize in advance. This is some of the worst part of the surgery in the front in the beginning, and then when you're asleep, you won't feel any of this, okay? You're doing great. I'll let you know how things are going as we progress, okay? So our patient's awake, as they always are. Needle here. We've injected 6 mil. Give it a minute to work. Our patient is awake, and I need him awake in the beginning. And we're eventually going to put him to sleep, but I need his help in the beginning to get to the 2 painful discs that we're going to fix. That's where we are? All right, so I want to be a little bit lower. How's his blood pressure? Yep, good. Yeah. Let's work on bringing it down just a little bit more. You let me know if it's hurting, okay? So for those who don't know, bleeding during surgery requires 2 things. You need a cut through the wall of a blood vessel, and you need blood pressure. So the higher the blood pressure, the more the bleeding, and the bigger the hole in the wall, the more the bleeding. So you can control the blood pressure and keep it low to minimize bleeding, and you can also keep the size of the hole in the wall or the blood vessel small, right? And there's a magic number that I found over the years. It's a systolic blood pressure of 110. Anything below that, you have virtually no bleeding. Whether you're doing open surgery, as long as you respect the planes and you stay within the fascial planes between muscles, as long as you use good surgical technique. Is that my latest shot right there, or is that not the latest shot? Can you give me the latest? Should be a little bit lower than that. There we go.
None of the patient.
Let's go to a lateral view.
We'll see if it's blocked.
So with good surgery technique, blood loss is truly almost eliminated. And at Deuk Spine Institute here, we've been doing spine surgeries going on 10 years now at our center. And we do all types of spine surgery, including open back surgery with fusions and laminectomies when needed. And our blood loss is almost nothing, you know, like literally 25 to 50 cc's maximum per level of lumbar fusion surgery. So the way we can keep the blood loss low is through good surgical technique and through keeping the blood pressure controlled. Sean? All right, we're aiming for the L4-5 and L5, L3-4 and L4-5. So I need to do a little bit lower. I'm going to go ahead and give my patient some more numbing medicine. I know this is going to be a little bit uncomfortable. We just have to numb you up a little bit more. You're doing great, by the way. This is the worst part of the surgery because you're awake for it, but I need your help to make sure I get into the disc properly. The problem is he has 2 damaged discs in his lower back, okay? L3-4 and L4-5. Actually, he has more than 2. He has a lot of damaged discs, but these 2 localize to where his pain is, that he gets all the time, his back pain. And that's why we're doing the surgery. We're doing the surgery to get rid of his lower back pain. So to get rid of the lower back pain, you have to actually fix what's broken that's causing the pain. And in his case, it's these 2 discs. How do I know that? Well, number one, his physical exam and his MRI scan. That's what's taught me that, or has shown me what's wrong, plus my many years of doing this and fixing people. So, now you see the pedicles of L4? They're a little bit offset with orbit. I think we just need to do a little orbital change on the fluoro. No, other way. Now we're using fluoroscopy, which is an X-ray machine. It's portable, that's good. It's better. It's portable, it's mobile, and it gives us instantaneous imaging as to what we're seeing. And that's what we're using to do a surgery. Sean? All right. So I'm using the X-ray machine to guide myself down to the bad disc so that we can repair it. Sean? Feels like the sets. Trajectory looks good. But what you're not seeing is that we're a little bit too medial. So we want to fix that, come a little bit more lateral. Sean? To get around the facet joints. All right. So to do that, I'm going to have to go a little bit more lateral with my entry point. You want to keep your entry point as medial as you can to achieve the goal that you want, but you don't want to compromise your ultimate destination, which is going to be that disc that we're fixing. Okay?
I know. It just never gets.
So I have to go through the foramen to get there. And the foramen is a small opening in the spine that's naturally there. And by using that small opening that's naturally there, we avoid having to remove bone and ligaments like everyone else does. Okay? So removing bone and ligaments is not good for a patient. It weakens the spine, destabilizes it. And the traditional spine surgeons, that's all they do, Sean, is remove bone and ligaments. We want to avoid that.
The final product.
Sean? All right, so we're getting a little closer. Can we get our blood pressure down a little bit?
It's good if you need the anesthesia.
And I keep having to redirect a little bit.
Very rarely the G projects your voice or something.
And again, it's finding just the right spot, Sean, to get around the facet, Sean, and into the foramen. Sean?
Yeah. No, it's 100%.
I think we're a little better this time.
100%.
Sean?
Can't say nothing about the moon's work. The guy is
All right.
superhuman, superhero.
So, I'll just take a moment. You can all see the tip of the needle, I think. Why don't you show them the tip of the needle? Are you on the X-ray?
Yes, they're seeing it on the floor.
Yeah, but you can use your pointer, right?
Yes.
Not you. Jordan.
Yep.
Yeah. So you can see the white arrow?
100% yes.
All right. Are you okay? right, good. Everything's going fine. Perfect. Shot. So I have to get down to the back of the disc where the tear is. Now, all of his back pain is coming from a small tear in the back of the disc, and that's what I've discovered at Deuk's Spine Institute. So why is that important? Because if you go talk to your spine surgeon and say, hey, fix the little tear in the back of my disc, they're going to think you're crazy, because they don't know yet that that is the cause of back pain when you have a herniated disc. So because it was discovered here, and that information hasn't spread yet, people are going to look at you funny when you say that, but that's how you fix back and neck pain from a herniated disc, is by repairing the small tear in the back of the disc. It's called an annular tear, and once again, we discovered that here at Deuk's Spine back in about 2006 or 7. All right, so the part that you're watching now, which is putting a needle percutaneously into the foramen, this is actually a pretty common technique because pain management doctors do it all the time to do epidural injections. Now, we need to make sure we're at the right disc. I'm looking at this and I see the sacrum down below. Point to the sacrum. Well, it's very important as a spine surgeon that you treat the right disc, or the right level, we call it. That's the sacrum, okay, where the white arrows. Now show them the L5-S1 disc space. It's completely obliterated. It's gone. Basically, something's happened in his past that caused that disc to basically fuse together with the bone above. Show them L5. Yep, so that's L5, vertebral body. Show them S1. That's a little lower. That's the sacrum down there, the ice cream cone. And show them the L5-S1 disc space that's now gone. Right there. Perfect. Now go up to the L4-5 disc space. That's it. So we are targeting L4-5 and the one above, which is L3-4. Those two discs are the cause of his back pain. And it's a small tear in the back of the disc that I'm going to fix today with the laser. We're also going to unpinch the nerve root. Okay, so let's get an AP view. We're making good progress. You doing all right? Again, our patient's awake, and he's not really getting any pain medication. He's awake. So this is not a very painful surgery. Okay, it's not like open back surgery where you have to be put out completely. That's perfect. Let's go back to a lateral. So you can see the tip of the needle is in the foramen, just about to enter the disc at L4-5. It's perfect. It's exactly where we want it. You have to use two views on fluoro, AP and lateral, sometimes oblique, a third view. But generally with the proper AP and lateral, you get the right shot, you can do what you need to do. Now folks, this is a $180,000 x-ray machine. Most doctors don't have it, okay? Most hospitals don't have it. They have the El Cheapo versions. With the El Cheapos, you can't see the anatomy. You can't see the disc. You can't see the foramen. It's very hard. It's like a blurry thing. So to do this kind of surgery, you have to have the best quality equipment, supplies, drugs, and technique to do it successful. All right, I can feel the herniation at this point with the tip of the needle. Are you okay? Good news, I think we're at our first disc. All right, sometimes we never know if we're going to get it until we get there and get it. But congratulations, we got the first one localized, okay? So what that means is things are going well. You're halfway done with the awake part. And then we're going to put you to sleep to do the actual surgery. Now here's the magic, folks. 7mm incision, 7 millimeters. Okay? 7 millimeters. The entire surgery is done with this tiny little cut, literally a 1/4 inch. There's no other surgery or surgeon in the world that does it like this. There are endoscopic spine surgeons that do this with a small incision, but they don't do the Deuk laser disc repair. All they treat is leg symptoms, not back pain. We treat and cure both, the back pain and the leg symptoms. That's what sets us apart. And the reason we're able to is because of the technique, the Deuk laser disc repair technique, which has been peer-reviewed and published. Are you comfy? Yes, he says, yeah. All right, the good news is, like I said, we're halfway done, okay, with the awake part. So let me show you while we're waiting, put a little pressure on the skin, just to stop the little bit of bleeding. This is, I'm going to show you his scar, okay? Wow, I can see it better now. There's a little white line here. It literally runs all the way up. Geez, someone really got you. Who did your laminectomy? Halifax, huh? It must have taken you a while to recover from the surgery.
Do you not pronounce
A long time, right? That's more than 10 inches. That's about a foot long. That's about 12 inches. So folks, you see it starts here, the scar, and it literally runs up to where the drape's end. And maybe even goes a little bit higher. That's the laminectomy incision.
Do you think
Scary, huh?
that means arthritis?
We're not doing that incision, don't worry. That's literally, yeah, it's basically as long as this thing, this metal. Okay? He had that done a year and a half ago. He's back having another surgery. Why? Because laminectomies suck. They don't work. Okay? You may get temporary relief for a few months, maybe a year, but then it's all going to come back because they've just removed the ligaments that stabilize your spine. So we're going to do this without taking any of the ligaments or anything out in the back of the spine that God put there that's supposed to stay there to stabilize your spine. We're going to fix his discs by going around the back stuff. All other spine surgeons that do open surgery, microdiscectomy, laminectomy, fusion, they all have to go through the midline, they go through the back, and they have to take all the bone and ligament out. Dr. Parvis Cameron discovered a way to fix this. Let's go back to the view. Dr. Parvis Cameron in Pittsburgh was an orthopedic surgeon, spine surgeon back years ago, and he discovered a way to go through the foramen. All right, from the side. It wasn't my discovery, it was his. And he taught a few doctors, but he had all kinds of complications because he didn't do it right, basically. He started the technique but didn't perfect it, and basically kind of stopped doing it. All right, let's center that L3-4 disc. But the idea of coming through the side, through the hole that's already in the spine, called the neuroforamen, and going through what's called the safe zone, you need a ragged to get that pedicle of 3 lined up. While we're getting the x-ray picture perfect, remember, you don't want to try to navigate with your needle until you have the x-ray picture as good as you can get it. That looks better. Yeah, it's bad. You can see there's a little retrolisthesis of 3 on 4. But the pedicle of 4 is lined up, I think, pretty good. The pedicle of 3 is pretty good. Our orbit is decent. It's just going to be a tough one because that foramen is so closed down. So Dr. Camden discovered this approach, and he named the area that we go through is called Camden's triangle, the safe zone, and it literally is an area in the spine that is between the 2 nerves. I had a phone call yesterday with a patient out of, I think, Canada, and he was going to get he had a microdiscectomy done, and it didn't work. And the reason it didn't work is because his herniation was in the foramen, neuroforamen. And when you have a herniation in the neuroforamen, you can't do a traditional midline incision because the herniation's way over here. You're not going to get to it. And so I was explaining that to him, how the Deuk laser disc repair works and how come it's so much better. Because I can get into the foramen and I can get the herniation right where it's hitting the nerves. Anything there? No? AP? So far we've lost about 3 drops of blood. That's it. And that's pretty much all we're going to lose. We're going to lose probably at most 20 drops of blood for the whole surgery. And 20 drops of blood is nothing. We call it a milliliter. It's looking good. Let's go back to a lateral. You have a question?
Yes, doctor. We have a question from YouTube. Can you describe arthrofibrosis and how it is treated?
I did not understand what they want me to describe. Can I describe what?
Arthrofibrosis.
Arthrofibrosis.
And how it is treated.
Yeah. Arthro basically means joint. Fibrosis means scarring of a joint. And arthrofibrosis is scarring of a joint. It comes from inflammation of the joint. Okay? All joints that get injured. Are you okay there? Any problems? Huh? No pain? Amazing. Chuck? So arthrofibrosis is scar tissue forming inside of a joint that's not normal. It's part of arthritis, inflammation of a joint. It happens usually as a result of trauma and osteoarthritis, and it happens as a result of autoimmune attack, your immune system attacking your joints in rheumatoid arthritis or other types of inflammatory conditions that affect joints, like Sjogren's syndrome and other autoimmune diseases, okay? And it's basically scar tissue in the joint. How do you fix it? All right, good question. So this, what we're doing right now, truly is that condition, arthrofibrosis. The disc is a joint, and fibrosis means scar tissue, and there's scar tissue forming inside this joint, and that's painful for patients. Anything? Where do you feel it? In your back, not down your leg. Oh, big tear in there. All right. Wow, perfect. You did a great job, sir. Can I tell you that? You did a great job. We did it. We're there. And we're almost ready to put you to sleep. But I gotta just check something, okay? And I want to finish answering this question. I'm going to come right back to you, okay? All right, so hang on for a minute. All right, you're watching a live broadcast, okay? And what are we going to do? What are we going to do when you're done with this surgery? What are you going to do when your back pain's gone and your leg pain's gone? What are you going to do, sir? You're going to go to Disneyland. How old are you? 51. So you're the same age as me. You remember those commercials? Right? What, Oral Hershiser, you just won the World Series. What are you going to do? I'm going to Disneyland. Remember when they used to get those athletes to say that? Whatever happened to those days? Those were great commercials. All right, so Disneyland's not so far away. You know, it's 45 minutes from here. But you're in Melbourne, Florida. Now, where did you come from? Michigan. To Alabama. All right. So you traveled here for the surgery, right? Well, you travel here no matter what, because you don't live here, right? I didn't see a bed or a sleeping bag or anything. But you traveled here, but you came from Michigan originally through Alabama. Is that correct? All right. Now, you had back surgery done a year and a half ago, huge laminectomy, didn't really work. You're back here having another surgery, okay? In the same place you had a laminectomy, by the way. That's because laminectomies don't fix pain, back pain, from a disc herniation. Because you're not, with a laminectomy, you're not touching the disc. You're just touching the lamina. That's the part of the spine in the back. All right? So your problem was always the disc herniation. And they never fix that with the laminectomy. That's the problem with laminectomy. They don't fix the disc herniations. So you're here, and we're going to fix your back pain. But I do want to finish answering the arthrofibrosis question. Because what it is scar tissue in the joint. It can happen at any joint in your body. Small joints in your fingers, happens with rheumatoid arthritis. Can happen in medium joints like elbows, shoulders, or big joints like hips and knees. And it basically just means you have a lot of inflammation going on in that joint because it's been injured. And that inflammation causes pain, and then the scar tissue causes pain. So you've got inflammation in your discs, and that's what's causing your pain. Okay? And we're going to fix that today. All right, so have you watched any of my surgeries before? What do you remember about what happens now? Not too much? All right. Yeah, you'd probably remember if you remembered. All right, so here is the L4-5 disc. Okay, L4-5. Here is the L3-4 disc. Now we know from his MRI that the L3-4 and the L4-5 discs are damaged. There's herniations, there's an annular tear, and through the annular tear, the jelly in the center is squeezed out. And it's causing inflammation, arthrofibrosis, inflammation of the joint, scarring of the joint at these two discs. Now, based on where he pointed to in the clinic, I think this pain's coming from these two discs. But there's only one way to find out, right? How bad is that on a scale of 1 to 10? How high did it go? An 8. All right. Thank you. Yeah, please keep that completely separate. How bad did that get? Huh? Which one, 9 or 10? It's okay, you can be honest with us. 10? 18, you said? A 10. All right. So that was the L4-5 disc. And is that where you typically get back pain? So that's 10 out of 10. And the reason is that it was an 8 before because he has such a big disc. He's a big guy. He's got a big disc. It just took all that dye I put in there and still didn't create enough pressure on the tear where the inflammation is to elicit a maximum response. So it's a 10 out of 10 and it's concordant. C means concordant. So I just tested this disc, L4-5, which I believe was a cause of his back pain and left leg pain, based on his MRI, based on his physical exam, and based on my years of doing this, and it's a 10 out of 10 pain. It's horrible. And you want to get rid of that pain, don't you? You're gonna. When you wake up, sir, that pain will be gone for the rest of your life. Isn't that great? Just don't re-injure your back, okay? You just don't bend at the waist for 6 weeks and don't lift anything heavy, and that disc will heal up. And a year from now, you can do whatever you want. You can play tackle football if you want to. Okay? All right. Now you know we're looking at 2 discs today. How bad is that on a scale of 1 to 10? 10. All right. Sir, we have found your 2 painful discs. When you wake up, that pain will be gone forever, and you're going to be a happy man, aren't you? All right. Now, what do you say to all the people out there that don't believe that discs cause pain? Yes, they do. Yeah. And is that your typical pain that we just elicited? All right. You get to go to sleep. I want you to count from 1 to 100 in Chinese. Okay, out loud so we can all hear you. All right, go ahead and count from 1 to 100 out loud. So he's counting, and the reason we have him count is because when he goes to sleep, which we don't know when he sleeps until his brain stops working, because when you're asleep, you're not using your brain, obviously, to count. So you stop doing conscious activity. So if he's counting and he goes to sleep, he'll stop counting as soon as he goes to sleep. So we can hear him stop counting. Keep counting! Yeah, you're doing good. So you see that? He kind of stopped counting. And then I aroused him a little bit just to see where he is. And he started counting again. Keep counting! No response. He's out. All right, a little one there. Lights out. So he's asleep in sleepy land, having a nice dream. And it's interesting because the medicine we use, propofol, actually apparently gives people great sleep. But let me tell you something, folks, if you're watching. Propofol, which is how we put our patients to sleep, is not a painkiller. Okay? It is not a painkiller. It's not a narcotic. It's not a muscle relaxer. It's not an anti-inflammatory. It's a sleeping medicine. That's it. So when our patient wakes up and he has no pain in his back anymore, it's gone. It's not because we gave him anesthesia that makes his pain go away, because we didn't. We used propofol. The thing about propofol, it's literally the best drug in the world right now available for putting people to sleep, and then they wake up. As soon as you shut it off, they wake up within like 2 or 3 minutes, completely awake, no grogginess, because there's no after effect of the drug. And they literally could go back to work the same day after the surgery. I know I've had propofol for my colonoscopy, and I literally went back to work that afternoon. Not seeing patients, of course, but paperwork. All right, so propofol is an amazing drug, puts people to sleep, but it doesn't kill pain. So when you watch the video of this guy after surgery and he says, my pain's gone, which he will, that's not because of any drugs we gave him, okay? Some people think, oh yeah, well you gave him drugs. No, we didn't. He's literally getting propofol. He got a little lidocaine in the skin. All right, you're fine. So he's getting a little bit of a response from the pain. This is the more painful area. You want to titrate him a little bit? Are you okay? Want me to wait a minute? So I'm communicating with my anesthesiologist. I'm waiting for her to give me the signal. She's monitoring his vitals. You want to give him a little bit more? So far, we've lost literally 6 drops of blood. And remember, we get to 20 drops, that's 1 milliliter, 1 mil. Normal back surgery like this, when it's done by surgeons, they're going to lose 1,000 milliliters. 1,000 mils for this kind of laminectomy he had, at least 1,000, maybe 2,000. We're going to lose 1. So it's 1,000 to 2,000 times less blood loss. You okay? All right, can I proceed? All right. So he's getting a little stimulation. Why? Because I'm right on the herniation. I'm exactly on the herniation, the thing that's hurting him. And remember, I told you, it's the back of the disc. Well, where are we? We're at the back of the disc, right where the annular tear and herniation is. We need him a little bit better control. Yeah, take your time, no rush, do it safe, always safe. Safe is important. So right now, the tip of my dilator, which is running down the guide wire, is literally sitting in the annular tear, right where the herniation was. And it's pushing the herniation back in. And we're going to go in there and take that herniation pieces out. But to do that, I need to get the scope in, and we're not ready yet. We just want to give the patient a minute to get a little bit deeper asleep. So putting people to sleep with propofol is a fine line between too much and too little, right? And there's this gap between too much is up here and too little is down here. They're wide awake. So as people go to sleep, put your hands here. Luis is going to show you the perfect place for the patient where they're asleep and not feeling any discomfort and not responding. So everyone awake, they start here. As we give them more propofol, they get closer to that perfect zone where you have the perfect amount of propofol floating through their veins and their blood, putting their brain to sleep. And then if you go too far, they stop breathing. So if you get up here where there's too much propofol, they die. And we don't want that. We want to keep them in this zone. It's a zone. It's not a line, it's a zone. And you do that by titrating the amount of propofol you're giving them in the vein during the surgery to keep the blood levels perfect so the brain is asleep, but you don't go over here where they stop breathing. Okay? So right now, our anesthesiologist is finding that zone for him. And every patient's different. It has to do with lots of things, you know? More things than I can name. All right. So what are some of the things that it has to do with? Well, if you think about all drugs, when they go in your body, they can be taken up by different tissues, right? What tissue do we want to take this drug up? We want the brain. The brain is where it's effective. Shot? The brain. Shot? So we need the brain to have this drug, but we don't need the liver, we don't need the kidneys, we don't need the fat, we don't need the muscles to have the drug, because it doesn't work there. It works only in the brain. Now, we can't just tap into his brain and deliver drug directly to his brain. Okay? That would be like crazy, dangerous. We're not doing that. So I'd have to expose his carotid arteries and directly pipe the drug into his carotid arteries. And that could cause a stroke. So we have to be happy with putting it in his vein, knowing some of it's going to make it to the brain, and the rest of it's going to go to other parts of the body that don't need it. So that's called distribution of the drug. Anytime you take a drug, whether you swallow it, goes to your stomach, dissolves, gets to your bloodstream, or it goes to your vein, or it goes from an intramuscular injection, or a sub-Q injection, or intranasal, or sublingual, or rectal. There are literally 10 different ways you can get a drug, even into the bone marrow of a person, if you want to. All right, you're doing fine, lay still. So, the distribution of the drug through the body is what determines half-life and the effect of the drug, basically, because the drug is going to get metabolized and it's also going to get distributed. And the half-life is really half of the time of the therapeutic effect. So how long it takes to basically get rid of the therapeutic effect or metabolize the drug. So the amount of fat the patient has, the amount of heart rate and vascular movement he has, you know, all those things, how his kidneys work, how his liver works. You know, people with a bad liver, they're going to metabolize certain drugs slower. So the drug stays in their body longer and has a therapeutic effect longer. All right, I think we're close to where we want to be. I'm advancing what's called the tubular retractor, and I'm pretty happy with where it is. We're inside the disc, through the tear. So we literally, this is important to understand for those of you watching, okay? And I get online all the time and I advocate for people to learn about these new technologies that are better at curing pain, back pain, neck pain, and safer, okay? And here's why. Folks, look at the difference. This was his laminectomy incision. Bloody, painful, and in the end didn't do anything long-term to help him. Please move that out. Okay, this is, pull that out. This is traditional spine surgery. This is what all spine surgeons are going to offer you. Highly invasive, big incision, bloody, damaging to the muscles, damaging to all your tissues, removing of bone and ligaments from your spine, which should never be done. Totally unnatural, okay? And look at this. My God. I could have done everything and much better with 2 of these incisions, 7 millimeters. This is state-of-the-art spine surgery. When you go to your doctor and say, I've got back pain, and they say, I don't know what's wrong, they just don't know what's wrong, but we do. We can fix it. When you go to your doctor and they say fusion, laminectomy, microdiscectomy, all of these horribly invasive surgeries that don't really work and they cause more problems for you, don't do it. They're all old technology. So one of the things that came out in the news last night was that the companies that make screws and rods for the spine that surgeons love to put in because they make so much money doing it, came out that the federal government has indicted the owner of one of these companies, I think it's Spinal Frontier, for fraud, basically giving kickbacks to spine surgeons up to $1 million for putting in screws and rods in patients. Okay? This is what you, the patient, is up against. When you are told you need an artificial disc, when you are told you need a spinal fusion, those doctors are offering you those surgeries, many of them because they're basically making a lot of money to do it. But that's not the best surgery for you. Sure, I make more money doing fusions myself, but I don't recommend that for patients when the laser surgery is a better option. And so, most of the surgeons out there don't know how to do this surgery. Like 99% don't know how to do endoscopic spine surgery to repair the disc. So basically, if you go to these spine surgeons, you're stuck with doctors who don't know how to do the latest surgery that's best for you because it's atraumatic, you don't lose blood, you don't get scar tissue, and this surgery works better than any surgery in the world to eliminate back pain. Far better than fusion, artificial disc, laminectomy, microdisc. There's no surgery in the world that comes even close to endoscopic tube laser disc repair for getting rid of back pain. There's a granulation tissue, it's all pink. The blue dye is the blue stuff is the dye we put in. And I'm just going to start with the laser. Hold this. I'm going to focus a little bit. So I'm going to adjust the focus on my high definition endoscope. It only needed a titch. Alright, so the metal you're seeing is the metal tube. And we are literally at the end of the metal tube. We're inside the disc, right inside the tear. And you can make out the tear right there. Okay, the white fibers were the annulus fibrosus, and the blue stuff is the herniated nucleus pulsus. And we've shoved the herniation back inside the disc so I can safely take it out with this grabber. Okay, that's the herniation right there. Okay, so we're going to take it out. Bam, gone. So basically this technique that I'm using, which was taught to me by Dr. Anthony Young, who is a proponent of this technique, which is called the inside-out technique, as opposed to the outside-in technique, which some endoscopic surgeons prefer. This is a safer technique, okay? Much safer. And you get to grab the herniation out from the middle of the disc where you shove it back in, where it was outside hitting the nerve, and now we push it inside the disc. It's much safer to work inside the disc where you won't damage any nerves rather than out in the foramen, okay? So why do some surgeons do the foraminal? I don't know. There's no really good reason. I know how to do it myself, but I choose not to because it's not safe. Okay? And they just accept that nerve damage as part of the results, whereas me, I've never damaged a nerve, ever. Okay? I'm a neurosurgeon, we don't believe in damaging nerves, and I've not ever damaged a nerve. Not in laser surgery and not even in infusion surgeries. Now, some people might think, hey, Dr. Deuk, you just don't know how to do fusions. It's funny. If you go back, I can prove all my fusions to you. If you look at YouTube, you'll see that I have probably 500 fusions, spinal fusions, in the neck and back, all on YouTube, fully broadcast. For the last 10 years, we've been broadcasting my surgeries, both laser and fusions. You can see lumbar fusion, cervical fusion, anterior cervical fusion, posterior cervical fusion. I've done them all, and I've done thousands. So I'm an expert in not just endoscopic spine surgery, but also in fusion surgery, and one of the best in the world based on my outcomes. Okay? So why do outcomes determine how good you are? Because in the end, what you're trying to treat is the patient's pain in their back or neck, and their radicular symptoms, which is the arm or leg pain, numbness, tingling, or weakness, headaches if it's in the neck, and then of course myelopathy, which is spinal cord damage. So the whole purpose of doing spine surgery like fusion is to get rid of pain in the back, neck, or in the arm and legs. So if you judge a surgeon based on their ability to get rid of pain, and then you factor in the rate of complications and the type of complications, you're going to see that you can scatter plot all the spine surgeons of the world, and you have some of the best at the top, and you have the rest, and then you have the worst. Okay? Our results are not all the same. It all depends on our technique, how we do the surgery, what we do the surgery on. There's so many variables. And to have the best results, you have to have the best outcomes for the patient with the most pain relief, and you have to have the lowest amount of complications, the fastest recovery, and the fastest return to normal life for the patient. If those are your measuring sticks, then there are tremendous differences in spine surgeons. And you, the consumer, the patient, has to know that. Because you're the one who's going to suffer through complications from your surgeon, or you're going to suffer through a poor result from your surgeon, or you're going to have a prolonged recovery based on what your surgeon does. So when you factor all those important things in, you're going to get basically a ranking of spine surgeons. And it has everything to do with their outcomes and results. All right, so there's some granulation tissue. That's where the pain comes from, the annulus fibrosis right there, the pink stuff. If you watch our video, and I'm going to have Diego run the video and play the video for you.
Yes.
We run lumbar, causes of chronic back pain. So this video animation we created to explain.
Traumatic injury to the disc can cause annular tears to form.
Okay? And it might surprise you to find out that it's from inflammation within the annular tear.
Pressure on the disc causes herniation of the nucleus pulpus through the annular tear.
Like everybody talks about, it's not a pinched nerve.
Inflammatory tissues develop within the annular tear, causing back pain.
Within the annular tear. And that was discovered here at Deuk Spine Institute.
The inflamed annular tear generates pain signals.
Thought about it over the years and have talked about it. Nobody has proven it.
Additional injuries can cause symptoms to worsen.
Every week with our surgeries, because that's what we fix is the annular tear. With the Deuk laser disc repair.
Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain.
We're watching it right now.
Signals travel up nerves to the brain, causing localized back pain.
Do you care to finish the last question, the
Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
That's how we treat it, with laser disc repair. So I thought it was obvious. But if you're having back or neck pain from a herniated disc and you have arthrofibrosis, which is basically what everybody has with a herniated disc as a source of pain, then this surgery here is the solution. If it happens in your shoulder, then you do a shot and you do physical therapy to improve the range of motion with both active and passive range of motion exercises to break up the scar tissue within your joint. But you gotta get rid of the pain first. If you don't get rid of the pain first with arthrofibrosis, you're not going to be able to do the range of motion exercises you need. The key to getting rid of arthrofibrosis in most joints, at least as an initial step, is to do range of motion exercises with therapy, both active and passive. It's very important. To break up arthrofibrosis in the spine, you go see a spine cracker, a chiropractor. Okay? The spine crackers. And they're going to crack your spine. That's what they're doing, is they're cracking your facet joints. That's where the arthrofibrosis is, in the spine. If it's in the facet joints. If it's in the disc, you get the laser surgery you're watching right now. So it all depends on where the arthrofibrosis is occurring. Is it occurring in the disc? Is it occurring in the facet joints of the spine? Or is it occurring in your shoulder, your knee, your hip? Wherever there's arthrofibrosis, the treatment is a little bit different. Gosh, these things are just stuck down. So we're moving our tube out of the disc, getting closer to the foramen, and there's just a lot of scar tissue here. This is all that arthrofibrosis we're talking about. Again, arthro is joint, fibrosis is scar tissue, and what you're seeing is a lot of scar tissue right here in this disc. You have the end plates above and below, to the left and right. How's our irrigation? All right, let me have. I'm just grabbing out the loose fragments. That's another herniation piece there. So why do we broadcast our surgeries? Basically to educate the public about what's really happening in the spine in terms of curing back and neck pain, what's available now. You're not going to get these answers from the doctors you see locally because they don't even know this treatment exists.
We have a question from Facebook. What do you do to determine if it's a fusion or just rather a cleaning of scar tissue?
Alright, so what do I do to determine if it's a fusion or cleaning of scar tissue? 99% of the cases are Deuk laser disc repair, what we're doing right now. Rarely is a fusion needed. So if you have a herniated disc or bulging disc and you have pain, it's laser surgery. Deuk laser disc repair, what you're watching right now. There is no need for a fusion. If you have a fracture of your spine where the bones are out of alignment and they're pushing on your spinal cord and they're moving around, wobbling, which is rare, then that would be a need for fusion. The laser surgery would not be appropriate with that kind of instability. Yeah. Well, it should be at 10, right? Sorry, 15. But not 20. This looks like it's 20. It's well, what's the rate? Huh. Really?
Really?
All right.
All right.
By the way, if you're interested in learning more about whether you qualify for a Deuk laser disc repair, question is, do you have pain? Yes. Do you have in your neck or back or thoracic? Do you have a herniated disc or bulging disc? Yes, then you qualify. As long as the pain is coming from the herniated disc or bulging disc, okay? And then the last question is, have you had the pain for 2 months or more? So we don't want to do this kind of surgery necessarily. Now, there are some exceptions. If you have weakness or numbness, where we do the surgery right away. If you have spinal cord compression, we do the surgery right away. He's responding a little bit, doctor? But in general, if it's just for back pain or neck pain, we want you to at least try two months of conservative treatment, which is physical therapy, stretching, and reconditioning and anti-inflammatories, usually. As long as you can take the anti-inflammatories, you're not allergic to them. Okay? So it's important that you try conservative therapy first for 2 months. Let the disc have a chance to heal. Look at all that inflammatory tissue. Look how pink it is. Now, if you watch our video, again, you'll see we have the pink inflammatory tissue within the annular tear. That is the annular tear right there. Let me know when I can proceed. You're doing good. Lay still. I don't know if you can hear me, but yeah. Oh, really? Because this is moving. This is the more painful part of the surgery. Because we're in the outer annular fibers where the most innervation is. So this is kind of the piece de resistance. Yeah. The inner annular tear is less painful because there's less innervation, less nerves. The annulus fibrosus is about 1.5 centimeters thick, and the annulus fibrosus is a really tough band of collagen and elastin, mostly collagen. The outer half of it has nerve fibers that are pain fibers. The inner half does not. Now the inner half can get pain fibers because of the tear, with ingrowth of granulation inflammatory tissue over time. And it gets innervated, but it never is going to be as innervated as densely as the outer annular fibers, which is where we are right now. That's why this is the more painful part of the surgery. It always happens near the end of each disc. Look at all that scar tissue. Wow. This is where all this pain was coming from. So we're basically eliminating the source of pain by zapping the annular tear fibers, debriding it. This is called an annular debridement. You can see it in the video. This is what gets rid of all the painful tissue. The tissue that causes the back pain, in his case, because we're working on his lower back. If we were in the neck, it would be the same tissue would be causing neck pain or headaches. Yeah, you're right, it was slow, huh? Seems to be more comfortable. Just about done. I need 1 more minute on this disc, and then we're going to move on to the next disc. Any more questions from our audience?
No.
Just about done here. There's the end of the disc right there, and this will be a place where a lot of discomfort originates from, the back corner of the disc. And this is what they call Cambin's triangle right here, because of Dr. Cambin. He's the first one to do this type of approach. An approach in surgery means the incision, where it is, and how the pathway down to the part of the body you're trying to fix. It's called the approach. You can think of it as how you get from one location to another. right? So if you go on your phone and you go to maps and you type in a destination, well, the global positioning satellite looks at your initial position where you are right now and where your final position will be, and they create a path or a route. And we call that the basically the surgical path. And the process of going along that path, we call that the exposure, the surgical exposure. You're exposing that deep part of the body you're trying to fix. Okay, so in this case, we're fixing the annular tear. This is the annular tear we've been fixing now for the last 15 minutes, and removing the herniation at the same time. So this is all part of our exposure. And that's the end right there. That's the end of the herniation. Now we're almost outside the disc. We're literally, the tube is sitting just outside the annulus and the annular tear. So you can see we went through the annular tear, and as we pull the tube back, we're zapping away the herniation that's sitting inside the annular tear, and we are also debriding the annulus right here. This is the source of his pain. He's nice and comfy, he's sleeping, he's snoring, he's having sweet dreams while we're doing this surgery. Yes, in the beginning he was awake because I needed his help, because there's actually a nerve right here that was getting pinched, and I could not, I don't want to put my needle through the nerve. If I do that, I'll give him paralysis. So I need the patient awake to help make sure I don't hit the nerve. Because if I hit the nerve, he's going to say, ouch. Pain went down my leg. And at that point, we stop what we're doing and we redirect. So we take a new path. It's kind of like when you have a traffic jam on your maps, and it's navigating you, and there's an accident in front of you. You got to stop. You got to go around it. You got to take a detour. So you have to redirect around that. So I had to redirect, you know, in the case of a nerve being in the way, I'd have to redirect around the nerve. And the needle and the patient awake is the most sensitive test for a nerve being in the way. The other day I was in Orlando going to pick my daughter up from volleyball, and I'm driving along my path, the usual path, and what do you know, a tree from the storm fell into the road. So there was a police officer there making sure nobody hit the tree and crashed, and redirecting everybody around the tree. So that's the same thing I had to do. You know, I've not done it with this patient, but that's why you have the patient awake to help you redirect. They're like the police officer standing there telling you, nope, you can't go this way, you have to go a different way. All right, we are outside the disc, and if I look up here, I'm going to see that nerve root probably. It's up there in the fat. Look how inflamed it was, all that redness and stuff. So that's where the nerve root is that was being irritated. Okay, and gosh, a lot of inflammation here. I'm just trying to clean up this corner that's sitting underneath the nerve root. All this inflammation needs to settle down, you know, and I can't make it settle down, but we can get rid of the cause of the inflammation, which is the herniation, and that's what we're doing. Most surgeons don't understand that pain from a herniated disc is an inflammatory problem. They think it's a compression or structural problem, but it's not. It's truly an inflammatory problem. All right, let's see the grabber. Now I'm working in the foramen, okay? This is kind of no man's land unless you really know what you're doing. There's a herniation I just took out from underneath the nerve root. It wasn't a big one, but the more you can get out, the better. Try not to leave anything behind that's going to hurt the patient. You want to be thorough. I don't really see anything more. A little bit of bleeding from the end plate. Let me just see if I can fish out anything more. That's good. That should do it. We're done. The herniation is gone, and now that annular tear can heal itself. Let me just zap a little bit more right there. All right. And you know, every patient's a little different. Hey, laser on, please. Every patient's a little different. Some have a faster, easier disc to fix, some have a longer. Okay, we're just about done with this disc, and then we're going to move on to the next one. I'm going to suck all the juices out. And we're going to help that nerve a little bit because it's so inflamed. Oh, yeah, we're going to, first of all, put some antiseptic in. We've never had an infection from our surgery. We don't want to start. We used to use something called bacitracin, and that was used for 100 years in surgery. No matter what kind of surgery you had, surgeons used bacitracin and irrigation. And basically the bacitracin was wonderful. No, I need to get it out. There's still water down the tube. Every time I irrigate, I need to get this dilator in.
Yes, sir.
See how it's filled with water? It's not really water, it's saline, but I call it water because it looks like water. All right. So his whole surgery so far, one disc has been done through a 7mm incision. Okay, we didn't have to open up his back and you know, fillet him open. We're going to finish the entire surgery and be done. And the bandage put on, patient woken up before we would even have done the exposure for his laminectomy, which the exposure takes about an hour and a half. And that's just to expose the spine, okay? That's what it means. It means to go from opening the patient's body up to expose the area so the surgeon can do the job. That's without even starting the actual work that is going to help the patient. So the first hour and a half of a laminectomy or laminectomy infusion is just opening the body up to get to the spine so you can work on it, okay? And then that's when the real damage begins. Once you start ripping out bone and ligaments. If you don't know what I'm talking about, give them a link, Diego, so they can watch a spinal fusion, lumbar TLIF, T-L-I-F.
Got it.
Put a TLIF link in. Click on this link. It's going to be a few hour surgery, but it's one of my fusions I did, and you'll see what I'm talking about. And just look at that surgery and watch it, compare it to the laser surgery we're doing right now. It's like night and day. That's why we promote the laser surgery so strongly for people, because it's better, safer, much faster recovery. Okay, so can you drop your fluoro at all, or you drop down? All right, let's bring the table up just half an inch. That's good, that's too much. Sean? Yeah, let's drop it down a 1/4 inch. Yep, all right, that's probably good. Okay, so we fixed already the L3-4, now we're going to do the L4-5. Let's take a look. All right, come off. I got to make sure my guide wire's in. Shot? That's there. It's good. So where the dark stuff is in the middle disc, that is the L4-5. All right, well. So he's got a little bit of muscular bleeding. Shot. Not a big deal. It's just venous. But we do want to apply pressure. So now we lost our about 3 cc's. So that was a little more right there from taking the tube out. Still far less than 1,000 or 2,000 milliliters. All right, we'll just apply pressure for a minute. You can see the guide wire running from out here down through the muscle and into the disc. Again, it looks like it's going straight in, but it's not. It's actually coming from the side through the neuroforamen. Okay? Through what's called Cambin's triangle, safe zone. And Camon's triangle, anybody that does a T-lift, we all go through Camon's triangle. Let's just put a little bit of pressure. All right, so the next step will be to bring my dilator down the guide wire. And what the dilator does, let me just show you while we're waiting. Diego, I'm going to show you the tip of the dilator.
Okay.
Can you see this?
Yes.
So this is about as wide as a pencil. Remember when you went to school and you were writing with a number 2 pencil? It's probably even skinnier than a pencil, to be honest with you. But look at the tip here. It's tapered. What tapered means is it comes down and becomes narrower and narrower to the tip. And what that does is it doesn't cut tissues, it spreads them. So if you go, in through a tissue, it literally pushes it apart. And then when you take it out, it hasn't done any damage to the tissue. So that's the beauty of using these minimally invasive tools, is that they don't actually damage the muscles or the fascia or anything. They gently spread them away so we can put a tube in and fix things. So there's really no damage to the body except for the incision. All right, I'm just going to wait another minute and then we're going to get started. Can feel we're in the soft tissues, going through the fascia. And now passing through muscle fiber right there. You can feel it. You can actually feel all the different tissues. Once you do enough of these, like I have, thousands, over 1,000, you can actually feel the different tissues. I can feel the facets. I can feel the foraminal ligament. I'm just going to wait for a second. How are we doing? Good? You can feel it go past the facet and the ligament. Okay. So right now we're literally sitting on the herniation, pushing it back into the disc. Now it's painful at this particular moment normally, but he's asleep. But this would be painful because we're going through the most painful part of the tear. And so he's responding just a little bit. You want to put him deeper, or are you okay? Shot? Is that where we're at there? All right. Yeah, shot. All right. So I'm going to pull the guide wire back just a little bit. Shot, and we are literally at the L4-5 disc. And this is starting to go in. He's not happy about it. Just lay still, everything's okay. You're doing good. All right, shot. As long as you're happy, he's safe. Nope, that's what matters. Safety first. Can deal with amnesia later. All right. Shot, I want to make sure you don't advance your dilator and that your dilator doesn't come back. See, it's coming back a little bit. Shot, and the reason it's pushing back is the pressure inside the disc is so high from inflammation. And so you don't want it to come back too far, otherwise you lose your guidepost. And that's your safety, is that dilator. That dilator guides this tube in properly. So you got to make sure you don't lose your guidepost. Yeah, that looks pretty good. Take that. Shot. That looks good. We're inside. It looks perfect. Let's get the fluoro out. So we use a lateral view to guide ourselves in. When I started doing these 16 years ago now, I took a lot more x-rays because I was, to be honest with you, just worried. I wanted to make sure that, I was doing it right and safe and I wasn't going off somewhere. Now, after doing it so many years and thousands of procedures, because I've done 1,300 patients, more than 1,300 patients, but each patient has an average of 2.5 discs. So if you think about it, I've done really almost what's 1,300 times 2.5? That's close to 3,000 discs. So me personally, with this particular surgery. I've done plenty of fusions too. As I said before, I've done over 1,000 T-lift lumbar fusions, and each of those is, again, 2.5 discs on average. So huge numbers of surgery in my career already. And as I said earlier, I'm 51, so I've got a lot of years to go. But like I said, this surgery that we're doing now blows away any other spine surgery to fix a painful herniated disc. All right, so there's our tear. The blue dye is staining the degenerated nucleus pulposus. The blue fiber you're seeing at about 12 o'clock is the laser fiber, and the glass thing coming out of it is the actual glass fiber. It's not the blue part, the plastic over the glass fiber, that transmits the laser beam of energy. It's actually the cleared thing. I'll stop for a minute and show you. You guys see that? So the blue thing is just a plastic covering, protective sheath, but then the glass underneath it carries the laser energy from the machine, which is a big machine at the patient's feet back here. Maybe you can show them the laser machine without showing any confidential information. You want to point to the laser machine there, Jeremy? Can you see it, Diego?
Is it on the left or right?
It's at the patient's feet. Just
Patient's feet?
head
Okay.
towards the feet.
Gotcha. There
Show
it
them
is.
what that laser machine looks like. You see that?
Yeah, I got it.
It's huge, right?
Yep.
It's like bigger than a suitcase.
And that cost a Ferrari?
It costs as much as a Ferrari.
Mm.
Yeah. I could have bought a Ferrari, but I bought a laser instead. But the laser is wonderful that we have it, because now we're able to do these surgeries whenever we have patients that want to get them done. We don't have to call a company and hope that their schedule's open. We can now do the surgeries when our patients want them done for the most part, and it's made a big difference in the convenience for our patients. So, that energy is invisible. The laser energy is invisible. People think that it's red or green. Yes, there are red and green lasers, but the actual laser energy in this Holmium YAG laser is invisible to the eye. You can't see it. It's not in the visual spectrum of energy. You know, all of these waveforms of energy are what we call electromagnetic radiation. Microwaves for cooking your food are electromagnetic radiation. Visible light, Roy G. Biv, the prism of light, those are all electromagnetic radiation. Infrared spectrum is a certain wavelength and frequency of electromagnetic radiation, and of course the laser energy as well. So we use a very specific laser, the Holmium YAG medical laser. It's designed for medical purposes. It's used for things like breaking up kidney stones. It's used in OB-GYN procedures. You know, I won't go into detail. And it's used for spine surgery, obviously. Huh? Prostate. Yeah, prostate. There's another one. Luis, have you been playing with this machine after hours? Yeah, prostate. So if you want to remove prostate tissue, it's really good for that. And it vaporizes the tissue. It delivers the energy directly to this abnormal tissue, and it literally just vaporizes it. By the way, this is scar tissue right here. That's what it looks like. It's all scar tissue. So we were talking earlier, somebody asked a question about arthrofibrosis. This is Yeah, please do. This is arthrofibrosis. It's inflammation and scar tissue within a joint. So, woo. Somebody else asked too, I don't remember when it was, how do you keep, isn't the laser beam hot, how do you keep it cool? We keep it cool by using refrigerated very cold saline. That's what you're seeing is a liquid. You just saw some air bubbles there because we changed our saline bag, but it's sterile saline. Can be given IV, IM, and we use it as irrigation. It's pretty standard in an endoscopic surgery. Now, some types of lasers you don't use cold irrigation, right? You use air or other gases like nitrogen, because nitrogen's inert, you know, can't explode. But we don't use those type of lasers. This laser we're using is the most advanced laser in the world. It's very safe. Some lasers are dangerous. They're the cheaper lasers, and they can actually ignite gases. So we don't have any gases here. We just use saline. Saline cannot be ignited. So it's very safe. And it also cools the laser and the tissue. Diego, any more questions from our audience?
No, not yet.
So if you've been watching from the beginning, you can go back to the beginning. Diego, you showed the picture of the MRI, right?
I did, yes.
Yeah. You can see how bad his discs looked on the MRI. And even though they look so degenerated, look at them. They don't look too bad. I mean, yes, they're damaged. There's scar tissue. There's herniation and annular tear, but there's still disc material here. It's not like they're devoid of a nucleus. So we're going to fix this disc, repair it, and this patient's going to do fantastic, okay? He doesn't need to have a fusion. He doesn't need an artificial disc. They would never put an artificial disc in him anyway, because he's got big facet joints, and he's had a laminectomy. You can't do that. It's contraindicated. There's some fat right there. You guys see that? Turn the light down just a little. I want to show you the fat. Right there. Turn the brightness down, one click. Maybe one more. All right, there it is. You see the fat tissue? It's kind of yellow. It was just a little overexposed. So that fat is around the nerves, and we're getting close to the nerves, okay? But the nerves are still hidden and protected by our tube. But I got to zap some of it because I need to get up here and finish this herniation. And if I don't get all this stuff here, he could still have pain. I need 1 more minute and I'll be done. And we don't charge extra for taking fat out. I hope I got a few chuckles out there for that one. Liposuction. And it's just a little more this is a herniation, by the way. It's the fat cells that are herniating into my surgical field. Herniation means to push through from one space into another. All right, we're done. I need 30 seconds. I'm just going to look laterally here and zap some of this, and we're pretty much done. Now, folks, I really want to do something here I've not done before, and we lost one of ours to COVID, and I want to have a moment of silence. I can't give you the name, but I do want to honor this person. Got to know this person quite well, and just out of respect, I'm going to do this for my staff here. You're all here so you can ride along. Okay? We're going to do just a moment of silence. I'm just about done here, and we're going to get it done. All right. Yeah, so I just want to take a minute to remember him. We'll miss him. All right, let's shut it down.
Lights on, please.
Okay. So I'm going to show you what we did here just in a second. I'm just cleaning out, putting a little antiseptic in there, clearing it out. And we know that the nerves here have been inflamed. And what's that?
Do you want one stitch?
You can if you want to. I think it might be a good idea.
Yes, sir.
All right, so let's put a little pressure right here. I'll hold it while you clean up a little bit. So we're done, and we just did 2 disc herniations, repaired them, and literally are going to take this man's back pain away. We confirmed that the 2 discs were causing his back pain, and what's causing the pain is a tear in the back of this disc called the annular tear. And all annular tears don't cause pain, but ones that are inflamed do. And the way they get inflamed is from the herniation. It's that nuclear material in the middle of the disc pushing out through the tear, getting wedged into the tear. We call that interposed herniation. Nobody talks about it because nobody knows how important it is, but we talk about it here at Deuk Spine. That is the source of inflammation within the annular tear, interposed herniation. And that's what we zap away with the laser. And all these surgeons that do endoscopic spine surgery, they don't use the laser like that. They only use grabbers, and they don't focus on the annular tear. They only focus on the herniation that's outside pushing on the nerve. So they miss the source of pain. I discovered that the annular tear was the source of pain for back pain and neck pain, chronic pain. It was probably the biggest discovery in my career. Maybe the biggest one I'll make in my lifetime. But now we're trying to get the message out to everyone so they understand it's a fixable problem. It just takes a simple surgery to do. And then you can avoid big surgeries like laminectomies that don't work or fusions that are unnecessary. You did great. Your surgery's done. Okay? We're just wrapping things up. So here's the incision, 1/4 inch. And I'm going to come over there and answer questions. So start typing your questions up for me. Hey, lay still. You're doing great. Surgery's done. Lay still. Lay still. All right. He's just waking up, so he's a little bit groggy. You good, Luis? All right. I'm going to call our EBL 3 mil. Please type up your questions and I'll come and answer them for you personally. Remember, we have a link embedded here as well. You got the link on Facebook and YouTube and Periscope and LinkedIn?
And LinkedIn, yes.
Nice. So you can actually click the link and watch one of my fusions just to get a comparison of the laser surgery versus fusion. All right, I'll be right over there. Give me a couple of minutes.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain.
Give me a countdown.
Wait, see something.
Take your time.
Alright, you're good. Take that FaceTime. It's just showing an ad, so you're not seeing anything.
Yeah, but they're not just sitting waiting, they're watching.
Okay.
Right?
No, they're not. Okay. Cool, you're ready.
Countdown always.
3, 2, 1, you're live.
Okay, everyone, Dr. Deukmedjian here. We have just wrapped up a Deuk laser disc repair on a patient who is from Michigan through, where did he say, Alabama? He's a big guy, but he had a big surgery done a year and a half ago, not by me. He had a laminectomy done. And the scar from his laminectomy is that long. They just tore out all the bone and ligaments in the back of the spine. Basically, these are the spinous processes and the lamina, and the surgeon just went through and just ripped all this out. Bloody, painful surgery, on painkillers for months afterwards, narcotics. And in the end, guess what? Laminectomy didn't touch the cause of his pain, which was the herniated disc. So a failed back surgery, classified as a failed back surgery. Why? Because he still had back pain, still had leg pain. The surgery didn't fix those problems. So the surgeons typically after this kind of surgery go around high-fiving everybody. Hey, great surgery, went perfect, patient survived, got all the lamina out. But guess what? The patient's still in pain and they still have their leg pain. They have back and leg pain, so they never fix the problem. So should a surgeon be happy and excited about doing a laminectomy when the patient didn't get better? No. That's a failed surgery. And that's what we're trying to keep people from having are these unnecessary, highly invasive, very painful, bloody, scar tissue inducing surgeries that don't fix the problem. So how do you avoid that? You go to a doctor who really knows what they're doing and can actually cure the pain. There aren't many of us in the world. There's only probably 5. And I don't even know who the other 4 are. I don't know of any surgeons that can cure pain consistently every single patient except for myself. It's not a bragging right. I'm just telling you. Don't expect to go to spine surgeons. There are 6,000 spine surgeons in the United States. 5,995 of them cannot cure your pain consistently. Once in a while, they get lucky with their surgery and a patient's pain goes away, but they don't have consistent. And if you ask them, what is your average pain relief in patients, they'll tell you 50-50 chance of getting better. That's their standard dialogue, okay? Because that's truly the result. The other flip side of this coin is not just getting better from your back pain and leg pain, getting rid of it, but also not having a complication, right? Not ending up in the ICU on life support after spine surgery that's supposed to be elective. This happens all the time, folks, not with me, not at Duke Spine, but elsewhere. There's a patient who I was just told about by another physician who said, my God, I wish you had done their surgery. They had pneumonia after surgery and then they died. This is a laminectomy surgery, pneumonia and died, okay? So how does that work? Well, the anesthesiologist, because they have a tube down, gave them too much fluids. Their heart basically started pushing against all that extra fluid and it just stopped. They had a heart attack. And then their lungs filled with fluid and they died, okay? Yeah. So save yourself from complications, save yourself from bad results. Go somewhere where they have a focused expertise on great outcomes, like Duke Spine Institute. Our patient just came down here because he somehow found out about us, probably online, and recognized the quality of our results, second to none. And now he just had his 2 discs repaired. He's in recovery, and he will literally be discharged by 12 o'clock. It's 10:53 Eastern Standard Time. It's almost 11 o'clock. He'll be out of here by around noon. So we'll have him up and walking in the next 30 minutes, and then we'll try to get a testimonial and live stream it for you if we can. You may want to edit it though, but we'll see. We used to do live stream videos from the recovery area. That's something we should try to do again. Our next patient is going to be a 2-level Deuk laser disc repair. He's got an L5 herniation, an L5-S1 herniation, and an L4-5 herniation, so 2 discs. And he's got back pain going into his leg. He's also a musician, and he's actually the head of band. I can't tell you where, but I like musicians. I think they're very creative people, and we need them. And so he's a leader in the community in music, and maybe he'll tell you a little bit more about himself later on after we get his surgery done. Okay, we're going to take the question from the audience.
Yes. So what prevents a disc from collapsing after the tear is cleaned out, and how does this disc repair itself?
So somebody is asking me, after you do your Deuk laser disc repair and you've cleaned up the annular tear with the laser and you've removed the herniation, how do you keep the disc from collapsing? It's a great question. So one of the things we do, what would cause the disc to collapse? Well, standing up and putting weight on the disc is not going to cause the disc to collapse. Okay, they're stronger than that, even with a hole in the disc. And by the way, there's lots and lots of people, millions of people with annular tears and disc herniations. As a matter of fact, if you're over the age of 40, you have an annular tear and a disc herniation. So why doesn't your disc just collapse? Because there's enough support there with the annulus and the nucleus and all the elements of the spine, whether it's the disc, the ligaments, the facet joints, the tendons, the muscles. Everything gives you enough support so the disc just doesn't collapse and the jelly come out. You have to do something. You have to take the body beyond normal physiological loads to get more jelly to squeeze out from that hole. So what could you do? Well, bending forward after surgery, what that does is it puts pressure on the back of the disc and forces the jelly out through that annular tear that I just repaired. So no bending. That's why we put our patients in a TLSO back brace, which is a thoracolumbosacral orthosis. It's just one of those plastic braces that have the Velcro, and they use those when they're out of bed. So no bending and no carrying over 25 pounds. So you can go back to normal activities the next day, but you cannot lift over 25 pounds for the first 6 weeks while the disc is healing itself. So it's really about restricting activities after surgery that keeps the disc from collapsing. It doesn't collapse on its own because there's enough supporting structures around it, your muscles, your spine, your ligaments and tendons. It just doesn't collapse on its own. But if you force more jelly out of it by bending or lifting too much weight too soon before it heals, you will collapse the disc more. Great question.
We have one more.
We got another question that came in.
This person's had 10 back surgeries and is fused from his sacrum to L1 and is now getting his neck cervical fusion. Just wants to know what you would recommend.
Yeah. First of all, we have a viewer from YouTube.
Yes, YouTube.
YouTube, who has had 10 back surgeries, right?
Yes.
I'm so sorry, man. 10 back surgeries. It should never happen. Never. Never, never, never. I'm going to give you an example. In my patients, I do big complex fusions, the biggest there are, multi-levels. And nobody does bigger wax than I do, okay, with screws and rods and everything. Here's an example. Yeah, that's one level right there. So if you look at all my patients that I do surgery on with fusions in their back, 1%, that's 1 in 100, end up needing more than one surgery. In other words, 99%, and I've done over 1,000 surgeries with fusion on the lower back. That means 999 of my patients don't need additional surgery. Only 1 out of 100 do. And typically they end up getting what's called adjacent segment disease, where they ruin the disc above. And the reason why my results are so good is, number one, my technique is different. It's in line with the most advanced technique for fusing. So a lot of surgeons make the mistake of not putting the curvature in the spine. You see the curve there? Okay. Well, a lot of surgeons fuse the spine straight. And when you fuse the spine straight, you're going to wear out the disc above or below your fusion. So that's a big no-no. And that's probably, in my opinion, the most common cause of adjacent segment disease you read about after spinal fusions, where the next disc above or below wear out. It's because the surgeon did not fuse the patient in good alignment. So what's the key to getting good alignment? To get that curve in there. There's 2 things I do that are just nobody else does, except for a very few spine surgeons who really know what they're doing. Number 1, I do osteotomies, okay? So what's an osteotomy? You see this bone right here? That's the facet joint. When somebody needs a fusion, the facet joint is totally abnormal and it's not really moving anymore, and it's so arthritic it's forcing the spine to be straight, okay? So I go in there and I literally cut that facet joint out. You can see it on all my T-lift surgeries if you watch them. And that way I can, look what I can do. I can actually get that segment to curve backwards. So osteotomy of the facet joint, it's called the Smith-Peterson osteotomy. I do it on both sides. I get rid of those arthritic joints that are keeping the spine straight. You want to get rid of that straightness, and you want to put the curve back. The second thing I do is I use a special table that the patient lays on for surgery called the Jackson spinal table. And they're a $150,000 table. They're made out of carbon fiber. They do something that no other table in the world does. They basically cause the back to arch and give you that beautiful curve, okay? And so most surgeons will fuse you on a flat table because that's what the hospitals have. They have cheap, flat tables. And those tables cost $10,000. The Jackson spinal table is $150,000 and it is just for spine surgery. So most hospitals won't invest the money to buy one. They won't want to spend the money, okay? It's expensive. So all these surgeons are doing fusions with patients on flat tables and they have flat spines. That's why you're getting so much adjacent segment disease. There's one more thing I do that's different, okay? And you see this cage in here? That's in the front of the spine, that cage. If you put a small cage, your spine is going to be straight. If you put a big cage, your spine curves. So I always put big cages to create the most amount of curve. So big cages, Smith-Peterson osteotomy, Jackson spinal table. By doing those three things that almost nobody else does, because their technique sucks, because they don't understand what they're doing. By doing those three things, you can avoid having to do multiple surgeries. Why am I sharing this with you? Not because I want you to feel bad about having 10 back surgeries. Trust me, I feel horrible for you. But because I don't want other people out there to go through the same thing. Because your story is far too common. All right, what can be done in your neck? Avoid a fusion. What's a fusion? It's going to be a metal plate and screws, okay? You don't want that. So we now have laser surgery to go in and repair the discs in the neck. It's all done with a 4mm incision. I go in with a tiny tube and I can fix your herniations without fusion, without metal, without hospitalization. It's called the Deuk laser disc repair for the cervical spine. And I'm going to have my buddy here, Diego, run that video for you so you guys can watch the cervical Deuk laser disc repair, how it's done.
Cool. All right. Just the lumbar.
Traumatic injury to the disc can cause annular tears to form.
There you go.
This is chronic neck pain. It's not the laser.
Traumatic injury on the disc can cause annular tears
You
to
can run
form.
it, and then we'll do the surgery after it.
Okay.
Pressure on the
Do you know
disc
where the
causes
cervical one
herniation
is?
of the
I
nucleus
use its new
pulpus
socks
through the
out to
annular
them
tear.
later, but I will send them the link on YouTube.
All right.
But don't worry, that's going to be on there.
Inflammatory tissue develops within
Yep.
the annular tear, causing neck pain.
Are we still live?
I muted you. Good on.
Thanks.
The inflamed annular tear generates
Can you
pain
update
signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.